This week on the BackTable podcast.
If you're not nerve sparing and you're resecting the sympathetic chain with everything, a lot of these patients hover around a heart rate of 120 to sometimes up to 150 sometimes, and it can take weeks for that to normalize. Now, some it gets better while they're in the hospital, but some will notice that. I've had these days people wear the Apple Watch that'll tell them what their heart rate is, and that will last for a while, even post-op once they're at home. It will go back down, but yeah, I think that's all sympathetic drive that gets disrupted with taking these out.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today. We have Clint Cary from Indiana University and Gagan Prakash from Tata Memorial Hospital. Gagan, Clint, how are you all doing today?
Doing well. Thanks for having us. Looking forward to the conversation and looking forward to getting into it. Doing really good, Aditya, and excited to be here at BackTable Urology.
Awesome. Well, I'm thrilled about this episode. RPLND, Post-Chemo RPLND, it's certainly an operation that's near and dear to my heart. And, I really couldn't think of two more qualified people to bring in their perspective. Clint, quaternary, Pentary Referral Center at Indiana, kind of a mecca for germ cell tumor management. Gagan is the Chief of Urologic Oncology at Tata Memorial Hospital, huge cancer center, high volume, advanced stage RPLND. So not only kind of getting into the disease, but maybe how the disease is managed in different settings is intriguing. So let's jump on into it. New diagnosis, metastatic testis cancer patient. Is that somebody that UroOnc and MedOnc is seeing at that initial diagnosis, or are you typically seeing them after they've had a visit or in consultation with your medical oncology colleagues?
Here, we have obviously a great relationship with our medical oncologist, and it goes either way. Sometimes the patients get referred in to both of us, and we'll see them in combination, and then sometimes they go directly to medical oncology. If it's pretty already well established, they're going to need chemotherapy up front. Sometimes even with bulky disease, we may see them together, knowing that just to kind of get that introduction to them, knowing that we're going to need to probably see them once chemotherapy is over. So for us, there's no defined template. It has to happen this way. It's a little bit of, what functionally works best, and they can see us both. And sometimes they just see medical oncology up front.
Sure. How about you all, Gagan? Are you guys seeing them on the front end? Generally, are the patients having had their orchiectomy in an outside hospital, or are you all doing them? How does that work?
Yeah, so we do have something called as a disease management group with a specific dedicated medical oncologist for GU. And because of the volumes, we are not able to control who sees the patient first. But we have systems in place to ensure that when the patient is seen first, either by the medical oncologist or the surgeon, the same protocols are followed. And we also have certain red flags in place. So if there's a patient with a high volume disease that needs to be on a chemotherapy ASAP, even if it's seen by the surgeon, it's red flagged and the medical oncologist is called immediately. Probably around 20% of our patients are the ones who have their orchiectomy done outside and then come to us. And we still see a lot of scrotal violations. So around 15 to 18% of our patients with germ cell tumor would have a scrotal violation, mostly, considering it to be hydrocele or some other benign pathology.
Okay, so that's kind of similar. If it's possible, we're not algorithm about it. I do like to kind of visit them on the front end. So at least the concept of possible surgery after chemotherapy is introduced, and it's not coming out of the blue that, you've just been through chemotherapy and now we may be looking at some substantial surgery. What are your all's practice patterns in terms of patients that you might consider going straight to chemotherapy without orchiectomy? Are there any kind of general criteria? Biopsies, yes, no? I'd love to hear what you guys do and then maybe offer my 2 cents.
Yeah, I like what you said too about introducing that concept of you may need surgery after your chemotherapy, just so that's not thrown out at them at the end. Again, we're fortunate our medical oncologists are well versed and they tell them that even if we don't see them. But I think that's helpful just to let them know. It could go both ways. The patient would like to know maybe after chemotherapy I'm completely done, to not have to think about it. But I guess I would err on more, more information is probably better than less. But the scenario you just mentioned, it definitely happens. I mean, the clear case scenarios are ones where it's a non-seminomatous germ cell tumor. Their AFP is elevated. They have bulky disease. Maybe they're in pain, back pain. If they have bulky lung metastases and things like that, not going to delay it, getting them an orchiectomy. It's some form of a mixed germ cell tumor, most likely, and they're probably going to need surgery afterwards. And so you kind of already know the pathway they're going to go down. That would probably be the most common scenario, is if they had a testis mass presented with bulky disease, in pain, and scenarios like that. Right. So we see those bulky diseases very often, and typically patients who are either symptomatic because of disease, or if on the cross-sectional imaging we can see that this disease is glaringly bulky and the markers are in thousands, we would offer these patients upfront chemotherapy. If the markers are unequivocal, then we don't need a biopsy. But if there is a doubt, then we would go ahead with a biopsy from an accessible site. And we actually looked at these figures because this happens like a common scenario over here where you have to offer upfront chemotherapy. And around 14% of our patients, around 14.2% of our patients are the ones who would have an upfront chemotherapy, and then an orchiectomy is done along with an RPLND. And what we found interestingly was that the disease had responded completely even at the primary in close to 50% of the patients. And we are wondering if, the blood testis barrier is not working over here because the testicular masses are on an average much larger, and they have probably, because of the bulk of the disease, or the size of the disease, the blood testis barrier has, kind of been breached, and the chemotherapy is able to reach the primary site as well. Just to add a little bit on the earlier thing. So, over here, in addition to the medical part, there are a lot of logistical issues for which we have to ensure that the patient understands that an RPLND would be required after the chemotherapy. We do end up losing a few patients after the chemotherapy because of, either the funds or various reasons. And so their arrangements of the funds, their prehabilitation, their arrangements for the stay after the chemotherapy, everything gets organized in the first week itself.
Perfect. Love that. Clint, what were you about to say?
Yeah, I was going to say, I agree with, the histology. I mean, most of the ones that we take out afterwards, either at the time of an RPLND or sometimes in the case of pure seminoma when we're not going to do an RPLND after chemotherapy, it's either, just treated germ cell tumor with no live components to it, or if it's a non-seminomatous tumor, then we'll just see teratoma. I don't see a lot of residual active, embryonal carcinoma, yolk sac tumor, those kind of things after they've gotten chemotherapy. It's usually treated cancer or teratoma. So yeah, there is the supposed blood testis barrier, but this chemotherapy is pretty effective.
Yeah, so kind of agree with all of that. I think at higher volume centers, foregoing a biopsy, if the diagnosis is unequivocal, certainly the AFP is elevated, that sounds like a pretty reasonable option. I think looking at the imaging, and especially the coronals, is always critical. If they've got a nice bulky tumor extending up the spermatic cord, I don't really like to do an orchiectomy in that context. Going back to the kind of response in the testis, we did some microRNA work in kind of a real world setting of patients receiving orchiectomy, and about 5 of those patients were post-chemo, and all their microarrays were negative. I mean, it's kind of intriguing to think about, almost you leave a marker lesion in place, a highly manageable marker lesion, give them their chemo, do the orc. If it's negative, likely you're not dealing with viable germ cell tumor, and then maybe you put them on a closed observation program, and if they start growing, then pull the trigger and do it for teratoma, which is statistically what you're going to be dealing with. The HCGs, sometimes in these, super bulky metastases, very high HCGs, Clint, your all's group has put out some data on the likelihood of either teratoma or viable germ cell tumor in kind of super HCG, pure choreo syndromes. Is that data robust enough to start making decisions on in terms of, post-chemo management?
Yeah, that was published a few years ago, I think, by one of our fellows, was the first author on that. I guess real quick before I jump into that, one thought I had I think the difficult ones to kind of pull the chemotherapy trigger without some sort of tissue diagnosis ahead of time are the ones who have bulky disease, marker negative. And so if they go ahead and get chemotherapy, you don't know, if it's seminoma, then you're kind of trying to decide about a difficult thing versus if they just observing any residual mass and doing something if something changes. Those are the hardest ones to make a decision on, especially if they're in pain, because then even getting them a percutaneous biopsy sometimes can take some time to get arranged. I think those are the most challenging to know exactly what to do with. But moving on to the really elevated HCGs, over 100,000. So the idea for that came about because we had done a few cases where everything looked like pure choriocarcinoma from a clinical perspective. Either they had or had not had an orchiectomy, but they had previously had bulky lung metastases, pretty bulky abdominal disease, gotten chemotherapy. The HCGs, which were in the six figures, had come down to normal, although our medical oncologists, a lot of times with those patients with really high HCGs, they will watch them for quite some time before they refer them to us for surgery. And sometimes they may even wait months, even after their HCG is normalized, because those are poor risk patients. So there's a decent number of them that are going to fail induction chemotherapy and need salvage chemotherapy before surgery, especially if they have multiple sites of disease. They're not going to rush them in for post-chemo RPLND. But if the markers remain normal for a few months, then they'll refer them. And we were doing some of these with really high HCGs at the time they were diagnosed, and they were challenging, they were difficult, and most of the pathology was always necrosis. And so I'm thinking, geez, we're putting these guys through some big time surgeries for not a lot of added benefit. And so let's look at this group with this and see. And actually, I don't know, to get back to your question about towards the end of it, I don't know if we have enough data to say, if you had pure choreo and you had chemotherapy and you've got bulky residual disease, maybe we shouldn't do surgery on you because it's always necrosis. But in that study, our data suggested that, if we do know that it's pure choreo, I believe, I don't know the exact numbers off the top of my head from that study, but almost everybody was necrosis. And there were, I think, one or two patients that either had a transformed teratoma or something like that. But it is an interesting thought exercise.
Yeah, I agree. It's a long day at the office, and it seems like it goes one of two ways. You're either watching that HCG kind of plateau, peter on down, which is well described in these kind of super choriocarcinoma syndromes, and you're like, okay, they probably don't have viable germ cell tumors. You do it, and shocker, there's nothing there, and it can be a tough case. Or you're watching it, and then all of a sudden, blip of the markers, blip of the markers, and next thing you know, their HCG's sky high again. One other thought I had is even sometimes they have bulky disease, as long as they can stand it from a kind of anesthetic perspective, if they've got these huge soccer ball size masses for whatever reason, I'll try to get the orchiectomy done just so they don't have to kind of handle that for the next 3 months or so. What do you think, Gagan? Anything to add on top of that?
I think the moment the HCG, when we looked at our RPLND numbers, the highest range of HCG that we had was around 21 lakhs, which would be, I think,
2 million, right?
2 million, yeah. So we know those patients are not going to do well. And I think we have the similar dilemmas about when to go in for the RPLND. Should we just wait and see how the disease is behaving? Exactly what Clint mentioned are concerns here.
Perfect. So yeah, and I think also if they start kind of uptaking, it's important just to check that brain imaging again, get an ultrasound on the other side, make sure that there's nothing kind of going on in those departments. All right, so we've kind of gotten to whether or not to do an orchiectomy or not. We've got plenty to cover here. So I'm guessing standard, non-critical, inpatient chemo type of patient, sperm banking, trying to get all that going in these scenarios where it's challenging. And we've got scenarios in place to try to get them inpatient sperm banking, some logistics required there. But okay, so we talked a little bit about choreo. I think it's fascinating. And my takeaway from that paper, and it's something like 90% fibrosis necrosis, is don't jump in. Give it some time, watch it involute, follow those markers. But are there other scenarios, whether that's sites of disease, appearance of disease, histopathology, where you're thinking, this patient's, they've got a RPLND coming, chip shot, pure teratoma, lots of it in the orchiectomy? What are some of the ones where this guy's got an RPLND coming?
Right. So I think typically patients in which they've had a salvage chemotherapy, I think irrespective of the size, we have to kind of go in. Some of these variant histologies also, I think for lytic cells and Sertoli's, we keep a very low threshold for staging RPLND, considering that they are not responsive to chemo. And yeah, teratomas, where we know that majority of the pathology in the testis on the primary site was a teratoma, and that's what we are likely to find in the retroperitoneum. And in those cases, even if we do start with the chemotherapy, we kind of monitor them early and then probably keep low thresholds for going inside and planning an RPLND for these cases. Yeah.
Yeah, as far as, things in the orchiectomy, clearly teratoma is going to put you at risk for having teratoma left after chemotherapy. We actually looked at our group of patients, and the increasing percent of teratoma is a predictor for the likelihood of finding teratoma. So one of the early studies that came out of our center was if you just had teratoma, yes or no, in the orchiectomy, and that predicted a greater likelihood of finding teratoma. And then we took it a step further and said, okay, well, not just yes or no, do you have teratoma? Is it 10%, 20%, 30%, 80%, whatever? And we did see a correlation with the higher percentage of teratoma in the retroperitoneum at the time of surgery, assuming there's a residual mass. And so I think teratoma in the primary testicle is an important predictor. Clearly, at the time of presentation, bulky or disease, it's hard to take a 12 centimeter mass and shrink it to nothing over the course of chemotherapy. And so those are patients that you're going to line up for a post-chemo RPLND most likely. Those would be some just additional additions to Gagan's comments.
Yeah, for me, if they've got cystic masses at any point kind of early on, that usually kind of tips me off that there's probably some cystic teratoma in there. A lot of efforts to help predict histology, some nomograms out there. I think the long and short of it is they're really probably not robust enough to safely omit RPLND. All right, so they've got their chemo, and we'll start with kind of the low-hanging fruit, residual masses in the retroperitoneum. Actually, let me back up. Complete response to chemo, of course, there's some different philosophical approaches to this, but maybe just to kind of keep it moving, are there scenarios that are complete radiographic responses where you would advise for a post-chemo RPLND?
Not many at Indiana. Obviously, I think most would know that we are advocates for observing complete responses. I think I can remember one recently where the patient, it had a mixture of some mixed germ cell tumor elements and PNET in his testicle. And he had some retroperitoneal disease. He got chemotherapy and his mass shrunk. It was kind of right at a centimeter, a little bit less than a centimeter. And we went ahead and did his just for concern of leaving PNET. So there are some, kind of one-off scenarios like that probably make sense. But just the standard germ cell tumor complete response, at Indiana, we're not operating on those patients.
Gagan, you mentioned salvage chemo earlier.
Yeah, so Aditya, I think I kind of, let me take both the questions again together. So, patients in which we know that we are likely to go inside, definitely, the earlier question, is definitely those bulky diseases that we see very often. And I think a lot of times we would see patients in which in the plain scan you could see calcification, glaring over there. And that these patients have a sizable proportion of teratomas. So that also does happen at times. Now, these kind of a scenario where your patient has received a salvage chemotherapy, I think we know that the 1 centimeter cutoff may not be very valid for them. And in those patients, probably, even if it's not meeting the 1 centimeter cutoff, we would still go ahead for RPLNDs post the salvage chemotherapies. I don't know what are your policies for the Leydig and Sertoli cells in case the retroperitoneum doesn't show any nodes. Do you always stage them if there is a primary, which is a Leydig or Sertoli?
Yeah, that's a challenging situation. That Leydig cell, Sertoli cell, most are benign, right? And you don't have to worry about them, but there is a small percentage that are malignant. But the only, the best predictive factors that we have are everything that comes from the orchiectomy specimen, and even those aren't perfect. And so the patients that we offer an RPLND for, because in those situations there is no chemotherapy that's going to be helpful for the most part. And so if they have usually 2 malignant features in their orchiectomy specimen, then we will offer them an RPLND. That's based on I don't think we even actually published it. We presented it in an abstract at one of the AUAs many years ago, but that was just based on our own data of seeing if they had, what's the likelihood of finding some microscopic disease in the retroperitoneum if you had 1, 2, 3, 4, or 5 of these risk factors in the orchiectomy specimen. So that's kind of how we handle those. If they don't have any risk factors, we don't do any surgery for those. But if they have 2 or more, we would offer them surgery for sure.
What about salvage chemo at Indiana, Clint? After salvage chemo, good complete response
Same as with induction chemo. If they normalize their CT scan, then we would observe them.
And when you get these smaller sub-centimeter nodes, but there are multiple of them, so you have like a 3 mm here, like a 4 mm and a 5 mm, all at short distances, para-aortic or inter-aortic cable, would you still follow the 1 centimeter cutoff of individual, or do you think that this needs to come out?
I think, some component of shared decision making. I watch sub-centimeter masses. When I counsel patients, I'm fairly promotional and biased towards that. But I do say, there's been a study and there's 140 patients and 12 patients relapsed and 4 of them died. So, at the end of the day, you got about a 2% chance of dying. Whether that would have been a salvageable scenario with early surgery or not is debatable. So it comes across as biased, but, I bring it up. I bring it up to them. And I think in these contexts, I would also kind of generally say the curative scenario that we're trying to ferret out is teratoma. So if we, re-image you in say 8 to 12 weeks and there's any change at all whatsoever, we're going to pull the trigger. But I don't think, necessarily jumping in is generally my preference. But I think it's, your point is very well taken, that I think you got to look carefully and see what it looks like. Is there anything left? Is it completely gone, or is there something residual taken? Was there some yolk sac tumor? How much did the mass shrink? All those types of things to make a decision.
Yeah, and honestly, to be fully transparent, that you have to bring up the Memorial data where they do operate on everybody, and they find teratoma as high as 20-25% of the time, even with normal CT scans. Our data would not suggest that. We don't see 20 to 25% relapses of all those people we observe. So there's some discrepancy, different patient populations perhaps. There's also kind of a famous story that Dr. Einhorn will tell sometimes about a patient who had some lung disease, got shrunk with chemotherapy, followed the patient for 25 years. He developed a lung cancer and had to have a mediastinal node dissection for his lung cancer. And they did not find lung cancer in his lymph nodes, but they found microscopic teratoma that had been sitting there for 25 years doing nothing. So I don't know. Who knows? But I think, it comes down to how many patients do you have to operate on to benefit one, right? Number needed to treat. And I think that number is pretty high. And so you're probably going to create some problems operating on everybody. Obviously, I'm biased as well, but I think that number needed to treat is reasonably high.
Okay, so masses greater than a centimeter. I do want to kind of get to some of the intricacies of the operation, but throwing it out there, short axis is kind of what I'm focusing on. I used to get excited about craniocaudal, moved a bit away from that. Greater than a centimeter, really, unless there's something that's a substantial contraindication, that's generally going to be an operation. Is that accurate?
Greater than a centimeter?
Yeah.
Yeah, for the most part. Without getting too far in the weeds, I would just say yes.
Okay. Yeah, the weeds are thick. Gagan, does that sound about right?
Yeah, so would I. I would agree with that.
All right, so we're preparing. We're going to talk to the patient there. Let's say, not ultra complex, retroperitoneal only disease. Actually, what does a more standard RPLND kind of look like to you? I'll throw it out there. Mass didn't shrink that much, suggesting maybe high proportion of teratoma without any substantial desmoplastic reaction. Solitary node, 5-ish centimeters, primary landing zone. That's kind of like a favorable post-chemo RPLND. Sound okay? What's the opposite end of the spectrum? When are you like, oh man, I've done a bunch of these, but it's going to be some work tomorrow?
Oh, any seminoma patient is just a nightmare. I wouldn't say any, but more often than not, those are just different beasts for whatever reason. But non-seminoma, standard, like you said, you get 3, 4, 5 centimeter tumor in the primary landing zone. If you want to move towards the template discussion, we've done obviously work in that over the decade or two. And if you had disease only in the primary landing zone and it was around those measurements we just mentioned and markers are normal, we would do whatever side it was, right or left-sided template. And our data would suggest that we're not seeing any recurrences on the contralateral side. And so that's kind of how we would approach a standard patient in that scenario.
So good risk, primary landing zone, good response to chemo, template dissection. I guess you kind of, for the sake of completeness, run through other data that exists. Gagan, how does that sound to you?
Yeah, so would agree with the same. So even we don't see many extra template recurrences for this kind of a disease. And we would generally try and do a nerve sparing on the opposite side if we get this kind of a disease. Yeah.
All right, so those are going to be the straightforward ones. What are going to be the ones so the seminomas, maybe again, I am happy to start out, tumors encasing bilateral renal hyla. I never kind of love those. Actually, vessel elevation, I kind of like that because there's going to be some room back there. If they've got bulky retrocrural disease, I think most of the time that's teratoma and it kind of shells out reasonably well. Interiliac disease, sometimes that kind of makes me a bit more nervous if you get into trouble over there. I feel like that can be a challenging area to sort out. Shockingly, despite the fact that I do boatloads of pelvic lymph node dissections for prostate cancer and bladder cancer, when they're stuck into the pelvis, that's kind of never fun. All right, so I'm kind of just, exposing my soul here, guys. Come on.
I agree. I would much rather be operating around the aorta or vena cava than around the pelvic vessels, just because there's so many more of them and they're not predictable. Whereas conversely, the aorta and vena cava are pretty predictable for the most part, where they are and where they're not. So the bulky pelvic disease is no fun. I've been in trouble in the interiliac location for sure. I don't worry as much about that location. The pelvic stuff is no fun. The bulky retrocrural disease can be a challenge too. We've been fortunate over the years to have an excellent thoracic surgeon that we do those with, especially as they extend up higher, kind of into more to that middle posterior mediastinal location. But and the seminomas, as we presented at this past AUA, we don't do a lot of post-chemo seminomas. And I think that is changing. The guidelines talks about this 3 centimeter thing, and we just don't, we've kind of gotten away from that. But we presented 13 patients, I think over something like a decade. So we don't do a lot of post-chemo seminomas anymore.
Yeah, I think there was actually a fairly nice multinational, multi-institutional review of histology after salvage chemo in seminoma patients, and the rates of viable germ cell tumor were 8-10%. So I think you got a good option. We've got a nice morbid option with surgery, and there may be some highly select patients that may benefit. Okay, so that's that all sounds good, and I think when you get up into that upper retrocrural area, you do want to be cognizant of maintaining vascular supply to the spinal cord and keeping an eye on the artery of Adam Kiewicz and all those kinds of things, which could lead to some really pronounced hectic complications.
Actually, just before you move on there, that actually brings up a good point. To do these, in my opinion, correctly, you have to, just from a pure abdominal standpoint, you have to take down all the lumbar arteries and all the lumbar veins, quite honestly, to be able to move these vessels around to get everything out from behind them as well. Doing that in the abdomen alone creates zero risk of spinal ischemia, unless maybe, you're operating on a 70-something-year-old with a calcified aorta and their collateral blood flow isn't very good, which doesn't happen that often, but it does come about from time to time. But when you do need to think about it, like you mentioned, is when you're doing combined surgery in the abdomen and chest, and as you go up into the thoracic aorta, they're also taking down those intercostal arteries up there. We actually, about maybe 8 to 10 years ago now, started where we have a protocol, post-op protocol, well, even in the operating room too. So when we're taking down all those blood supply, basically from high up in the chest to down into the pelvis, kind of treat them like those really big thoracic and abdominal aortic replacements that they do for vascular disease, where you're keeping their maps very high in the operating room and post-op. Try to increase blood pressure just to create that collateral flow, make sure that they get good blood supply to the spinal cord. But that's really the only scenario where that comes into play. Standard RPLND, that's not really a risk.
So I think I'm scared of or worried about, the 4 retros. So the first one is the retro-aortic. Typically, when you see that the lumbars are pulled up because the mass being behind the aorta, sometimes it resembles almost like a jellyfish. Because, on the arterial phase, you can see the aorta and the lumbars pulled up. I don't know whether to call it a jellyfish or an octopus, depending on which part of the world you are. Then, of course, the retrocavals, which are right at the hilum. So when, the point where both the renal veins are coming and the mass is behind the cava. And the third retro is the retrocrural, which can sometimes give you a problem, especially if it's on that side at the level of the SMA. And I think the fourth one is at times when you get these retroaortic renal veins and the mass is sitting bang on it, an aberrant vessel, and that can sometimes give you trouble.
Yeah, I appreciate that. Retroaortic renal vein is just kind of a loss of a good friend where you just kind of know where your upper limit of the dissection is. All right, so just a couple of things that I wanted to make sure. So counseling, usually I'm pretty much like a 5-ish% viable germ cell tumor, 50% teratoma, 45% fibrosis necrosis. Is this roughly in the ballpark of what you guys are telling patients?
I think it's 40-40-20 for us. So viable, which is generally 10 to 15 in most quoted literature, for us is around 20%. And I don't know if it's because we are seeing a higher risk disease, and with, as I mentioned, diseases which are bulky and tumor markers which are, really high. And we sometimes feel that, just like there is a highest risk or a very high risk in non-muscle invasive bladder cancer, we wonder if we have a poorest risk for our patients with these kind of bulky disease. And
I'm curious, Gagan, what's the kind of standard chemotherapy induction regimen that you guys use?
So the induction is BEP 4 cycles. So, and if there's somebody is likely to have, the lungs are not good and a bleotoxicity is expected, we would use a VIP 4 cycles for 2B and higher and stage 3 disease. Yeah.
For us, it's kind of more along those lines that you mentioned, Aditya. It's, 5-ish% chance of malignancy. And then kind of the standard, is about half the other two. But that changes, that's like kind of out of the box, like standard, this is what we may find. But that's obviously individualized to patients. Like we were talking about earlier, if you had 80% teratoma in your testicle and you got a cystic mass in your retroperitoneum, that didn't change with chemotherapy, your actual risk is probably closer to 100% teratoma. So you can individualize it a little bit, but that's kind of the standard. If you group everybody together, kind of more group level data.
Okay, so patient counseling, I usually start out, I'm going to tell you about the common things, I'm going to tell you about the bad things. Before I offer my 2 cents, how does this conversation go like for you all? Gagan, why don't we start out with you? Patient counseling, here's what to expect.
Obviously, most of them are younger boys with very, very anxious parents, and I think all of us have to go through that. We tell them about all the risks. So the commonest things like the ileus, which could be sometimes prolonged, and chyle leaks are still almost 20 to 25% with us over here. But the more dreaded ones, requiring, say, vascular reconstructions or, say, nephrectomy, additional procedures, or a prolonged ICU stay and such things, is something which we tell them. But we also tell them that in the last 200 RPLNDs that have happened in this place over the years, this is the number of times it has happened. So this is, I think, one surgery where when we use the rates of complications for counseling of our patients, we ensure that we tell our rates and the updated rates of complications, because these rates could really, really vary amongst the centers and in different parts of the country. So that's how it is. We've been actually looking at making some 3D animation models or videos to explain this to the patients, because explaining about how these masses could be intricately related to the great vessels and what are the risks which we are likely to fear or which we are likely to face might be better explained by these models. I mean, when we could do these 3D models and for our partial nephrectomies, maybe it's time we should try them for our RPLNDs as well.
Totally, and it's not lost on me. It's not like a post-chemo RPLND is a post-chemo RPLND. They can be very different ends of the spectrum, but again, maybe just kind of out of the box, garden variety counseling. Clint, what's your kind of post-chemo RPLND counseling spiel look like?
I mean, obviously you have a little bit more risk than when compared to a primary RPLND. There's, depending on the CT scan, like you said, I mean, this is not, every RPLND is different. Every post-chemotherapy mass is sitting somewhere different. It's touching the aorta or vena cava in a different spot, whether it's the renal vessels or down near the bifurcation where it may be hard to get control of. And so, we go through the risk of bleeding, needing a blood transfusion. Usually if we're going to do some vascular work, we have that planned ahead of time, although doesn't happen 100% that way. And obviously, depending on their CT scan, we'll counsel them about possible nephrectomy if we need to do that. Sometimes we have to counsel them about a possible duodenal resection and things like that. A couple of things I found kind of with the more standard ones, a lot of patients will get, particularly if you're not able to spare nerves with these bulkier disease, a lot of patients will get pain in their thigh, which happens not while they're in the hospital. It's usually after they go home. And it can be pretty intense. It's like a nerve type pain that patients complain about. It goes away, but it takes some time. I don't always explain that particular thing to patients ahead of time just because I feel like we're talking about so much. I don't want to overwhelm them with all the potential thing that's going to happen. But I try to tell patients at least when they're going home from the hospital after the fact. And then some patients with really bulky disease, things that we'll see happen, particularly if you're doing retroperitoneal dissections, and let's say they have bulky disease up around the portal vein and SMA, celiac, and you're having to, either you or your general surgery colleague is doing all this work up in this area as well. You take away a lot of the sympathetic chain and the ganglia up there. A lot of these patients will have rapid GI transit, otherwise known as diarrhea, for quite some time afterwards related to that. So those are unique things, kind of only a subset of patients go through, but that's an interesting thing to see happen with these really bulky dissections. But more standard is kind of similar to what Gagan was talking about with this kind of leg pain as an addition.
So Clint, this was the sympathetic chain was something which has often intrigued us. In terms of, do you think that it does lead to some tachycardia or a prolonged tachycardia in the post-operative period, even if the patient has been adequately replaced with the fluids and blood? I mean, often I've noticed that there's a differential temperature in the lower limbs of these patients after having handled or maybe injured the sympathetic trunk. Do you think there's a relationship with this?
Yeah, 100%. If you're not nerve sparing and you're resecting the sympathetic chain with everything, a lot of these patients hover around a heart rate of 120 to sometimes up to 150 sometimes, and it can take weeks for that to normalize. Now, some it gets better while they're in the hospital, but some will notice that. I've had these days people wear the Apple Watch that'll tell them what their heart rate is, and that will last for a while, even post-op once they're at home. It will go back down, but yeah, I think that's all sympathetic drive that gets disrupted with taking these out. So yeah, that's definitely real. And patients, they will notice differential temperatures, and they've actually just had a patient email me about it this past week. And that leg that you did that to won't sweat, and that foot won't sweat. And I've had people tell me they've done all kinds of things. They put a sock on with lotion inside of it, trying to keep their foot, moisturized. So yeah, this happens, and I think it's related to that.
Yeah, so I think the duodenal part, if they came with a GI bleed, sometimes, which they do, I think you got to be kind of ready for that Coker maneuver to be somewhat hectic. I think you guys generally covered it. Garden variety, as long as it's like a huge mass occupying the entirety of the introitic cable space. I typically quote preservation of ejaculatory function rates at about 80%. That's compared to closer to, high 90s for primary RPLNDs. Ascites, I'm kind of more in the 1 to 3% range are the numbers that I will generally quote. And maybe we can talk about ascites and management of ascites here in a bit. The other big ones, I do mention about a 1% chance of dying as a part of the kind of the big ones and the common ones. But the common ones, like, bleeding, writing, blood transfusion, everything that you just mentioned, I really try to focus on a possible risk of anejaculation, a 1 to 2% risk of chylous and then, somewhere around a 1% chance of dying.
Yeah, chylous ascites, it's low. Now that changes with the bulkier the disease. If we're resecting the vena cava, that risk goes up. But yeah, on average, it's pretty low. Same thing, nerve sparings, with post-chemotherapy, sometimes you can do it and sometimes you can't. Obviously, just depends on how the residual disease is. So we talk through that. So yeah, I would definitely agree with those things.
What about extra retroperitoneal sites of disease? Maybe just relatively common ones, I should say. Liver, neck, lung, retrocrural, interiliac. I'm happy to share what I'll typically do, and then we can get your all's opinion. So, there's obviously varying rates of concordance and discordance for retrocrural. First off, I guess if there's persistent radiographic disease, generally broad strokes will try to handle it in the retrocrural area. The liver concomitantly. Maybe I'll just pause there to get your all's takes on that.
So I think it would depend on the intensity of what kind of a hepatectomy is required, and also what is the kind of blood loss and intensity of the surgery and the time required for the surgery from the retroperitoneum. Also, things like if there is a nephrectomy required in the retroperitoneum, so doing a nephrectomy and a hepatectomy at the same time is something which we would not want to go for. So there'll be various factors which would help us do that. So if it's like, a small lesion in the liver and not a very bulky retroperitoneum, then we would do it at the same time. But if both have are of higher intensity, then we would prefer to do it staged. We can sometimes get tempted because, you are there at the abdomen, but I think one has to just pause after the first surgery and then say that, hey, do we want to go ahead, or it'll be safer to do it as a second surgery?
Yeah, I think that's very reasonable. I think if we can do it safely, we're going to do both at the same time. We've put out data in the past where there is quite a bit of concordance. If there's necrosis or fibrosis in the retroperitoneum, 90% of the time it's the same thing in the liver. And so it lends credit to, staging them. If it's anything complex, it seems reasonable to stage it. If it's necrosis, then maybe you don't have to go back for a complicated liver surgery. But yeah, on average, we take a look at the films and talk about it with our liver surgeon. And if it's something that we feel like we can do both of them safely, then we'll try to do them at the same time.
Yeah, I mean, again, it's so hard to put all these things in like neat, tidy boxes. And, ideally, you'd actually do the liver first, right, under low CVPs. And that just kind of makes all of that easier. But you've got to make sure that you do the highest priority operation at hand, which is typically the RPLND. And, if that's a 8-hour banger with all your cavotomies and aortotomies, maybe a added liver resection is not in the patient's best interest. All right, so generally, if it's kind of straightforward, knock it out, you're there. If there's anything complex, RPLND first is what I'm hearing. And then the liver, not to mention, you get this wonderful exposure, and the liver folks come in and they just kind of make it go all to heck real quick. So, okay, fantastic. And next, some people talk about doing the neck and the retroperitoneum at the same time. Good idea, bad idea, any opinion?
We just did one about 3 weeks ago now. Yeah, it makes sense. Obviously, it depends on the disease, right? But yeah, I think when it makes sense to do them at the same time. I mean, you consolidate into one surgery for the patient, but it depends on how complicated one or both are. But yeah, I think when you can consolidate them, and same thing goes for in the chest, lung nodule or something like that maybe got bigger as well. So you're worried about that being teratoma, that you can combine with a VATS or a thoracotomy, depending on the situation. We try to combine them when it makes sense. And if it's going to be something where, the abdomen is the predominant problem, then we'll say, listen, we got to take care of your abdomen first. We don't think we can do both. It's going to be too much surgery for you in one day, and you'll come back for this other surgery. So I think it's just trying to put together and see what your skill set will allow you to do in one day without overwhelming the patient.
Yeah, so for us, the retroperitoneum and the neck is the commonest combination being done concomitantly for two reasons, because this combination is something which you could do simultaneously. I mean, the neck surgeons could stand at the other end of the table and do it. And also because head and neck cancers are so common in India, our head neck surgeons are like really, super surgeons, gifted and really fast. So most of the times we are able to do this combination together, but a VATS or a lung surgery is generally as a second sitting. And if it's a VATS, then we would maybe combine with the retroperitoneum one side, compare both the pathologies, and then see if the other side chest needs to be operated upon or no.
Yeah, and that kind of is consistent with the retroperitoneum doesn't necessarily always predict the lung, but one lung predicts the other lung. Does this sound about right?
Right.
Yeah, we wouldn't do both sides of the chest at the same time. That's kind of a lot to recover from, for sure.
And any kind of particular, Clint, I have to imagine that you guys have your kind of post-chemo RPLND anesthesiology team. Maybe you all do as well, Gagan. We don't really have a post-chemo RPLND team, but anesthesiologists, what are the things that they're going to be kind of dialed in on?
Yeah, we have a number of anesthesiologists that are well-versed. Some of them, grew up in the program, trained here, and then stayed on staff, so they've seen a lot of these. But yeah, it's critical to know, bleomycin, keeping your FiO2 on the lower side, on the very low side, and fluid management. That doesn't mean you're running these patients dry like you would for like a pure liver surgery, but just being cognizant of not giving them what they need, but not giving them too much. That in combination with the FiO2 levels are kind of the big things that they need to be cognizant of.
Right. So we do have these supramajor resections at various sites. So I think most of our anesthesia people are used to, I would say, heroic and adventurous surgeries with massive blood losses, and they manage them well. But I think one thing which we've kind of learned from our pediatric colleagues, and which our anesthesia people kind of insist, is about the traction on the mesentery, which could be for hours together. So whereas if we get the entire bowel up and packed, our field of the surgery is far more comfortable, especially when they are major masses. But they said that if it is possible, then take the mesentery in certain gaps. So let the mesentery fall back for some time, or operate in one area, let the bowel be on the other side. And they believe that probably that could prevent, or kind of improvise a lot of things for the patient, including the third spacing and various other things. I don't know whether that really makes a difference, but at least for the pediatric population, pediatric surgeons, they feel that has made a lot of difference for them.
Yeah, I appreciate that. I definitely, if I am going to put the bowels up on the chest and pack them out under a towel or whatever, I'll definitely set an hourly timer just to kind of make sure I take a peek at them episodically and nothing kind of hectic happens there. All right, so we've counseled our patient. We've talked to our anesthesiologist, and we're finally kind of getting ready for the operation. We haven't even really talked about careful review of imaging and what that, what your prep work looks like. And I mean, this has been fascinating. I was a little bit afraid of this, that an hour would pass and we haven't actually got to the operation. So out of respect of your time, Clint and Gagan, and for our listeners, I think we actually have to save the actual operation for a subsequent chat. How does that sound?
That's a good cliffhanger right there. That'll bring them back for more.
It's basically like Top Gun Maverick for germ cell tumor nerds. Well, hey, I think, to me, this has really just demonstrated the nuances, the thinking, the planning, the multidisciplinary, complex nature of managing these patients really from the get-go. Again, as we kind of approach an hour, maybe, Gagan, we can start with you. Any kind of general advice, parting thoughts for the listenership?
So this was my first podcast, and I would say that I've just tasted the blood, and I'm sure I'm going to long for more of it. And let's take it to the next one. I think a lot of things in RPLNDs, but I feel that somebody who's getting trained as a urologist, irrespective of which center you're getting trained in, one should take an opportunity to at least observe a few RPLNDs, even if you have to travel across centers to do it, because I think having witnessed a few RPLNDs is going to make you a good urologist, even if you don't end up being a urooncologist. It teaches you a lot of things. Once you have kind of befriended the retroperitoneum, then it makes you a better surgeon in all aspects.
Yeah, I think basically really what you're speaking towards is experience and trying to get as much as you can, whether it's, seeing as many as you can or talking about this. I think just from our conversation today, you can see this is a complex, for something that is pretty rare, right? Testis cancer is pretty rare. There's a lot of nuances to it. And so I think, trying to get as much experience, if you're a patient, trying to go somewhere where you're going to benefit from experience, I think is important. But yeah, I mean, I think the more you can see, the more you can be around it, the more you can talk about it, hear others talk about it. I think it just increases your knowledge. So, because this is not something that's, this isn't prostate cancer that's happening in every hospital all across the world. And so you gotta immerse yourself in a rare disease and try to see and do as much as you can to gain these little nuances.
Well, I absolutely appreciate that. I mean, for me, I think there's two cases in urologic oncology, RPLNDs and cable thrombus, where there's so much variability. You've just got to be dialed in. You've got to run through your steps. You got to prepare the team. You've got to study the films. You've got to kind of run through all the possibilities in your head. And the variability is actually, I think, part of the draw. It's not routine. It's not standard. The only things I would add were, as you're starting, I think there's very little downside to doing these in conjunction with people that have done more of them. These can turn on a dime. As an attending, I'm pretty hands-on. It's kind of not the point of this, but as there's been a shift away from open surgery to minimally invasive surgery, sometimes I feel like a experienced set of hands can be a little bit more challenged to come by. But again, a wealth of knowledge here between Clint and Gagan. Absolutely appreciate it, and stay tuned for the sequel. Thanks, guys.
Yeah, that'd be awesome.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz. with support from
Devante Delbrun.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.